Hi, I'm Dr. Michael Fossel. This is going to be a somewhat different talk than many of the ones elsewhere in this conference. I chose this title because it's sort of an eye catcher and facetious in some respects, but accurate. Everything works in mice, but nothing works in humans, because it's a problem that we often have when we're dealing with, for example, age-related degenerative diseases, but with biomarkers in general. Really what I'm going to address is a unified systems model for targeted therapies. Specifically, the question is, can we do better than we currently are doing? And part of that involves not simply focusing on biomarkers, but on what the biomarkers mean. So one of the differeces I want to point out is the difference between knowledge and understanding. Too often we have a great deal of knowledge, which we need, but it's understanding that we lack. There's an old saw in science that if you can't measure it, it's not science. But beyond that, if you don't understand it, it's still not science. This is a quote from Einstein, who I think put it quite aptly. If I go back, for example, 500 years and look at the Ptolemaic theory of the solar system, the problem was not that the Vatican astronomers, for example, lacked knowledge. They had a great deal of knowledge about planetary positions, in fact, very accurate knowledge. The problem was they had no understanding whatsoever of orbital mechanics in any correct sense. So it took people like Copernicus and Galileo and Kepler to come up with a better understanding of what that data actually meant. And to some extent, that's the kind of a problem that we have when we look at biomarkers. We have a great deal of biomarkers, as we should, and a great deal of understanding of how to measure them accurately and validly and reliably, as we should. The problem is we sometimes lack an understanding of what they mean. So while we understand, for example, AB ratios and we look at various subfragments of tau and phosphorylated taus, and we have a great deal of knowledge about some of the upstream genetic biomarkers, that doesn't help us to understand how that results in the presentation we see clinically, as well as the time of onset, the clinical course that varies between patients. There's a great deal of clinical heterogeneity, and the question is why? Why do we get different sorts of measures in our biomarkers and different sorts of clinical syndromes, whether it's Alzheimer's, Parkinson's, or as you see here, the usual litany, alphabetic litany of various age-related vascular or age-related neurodegenerative diseases. So what I'd like to talk about overall during this talk is a unified systems model. And it's something that has been dear to me for about 45 years since I got my MD and PhD at this campus and first got intrigued by the underlying pathology in age-related diseases, culminating into a talk I gave here at the NIH 25 years ago, the first one in history. And what I was suggesting was that if we could truly understand the aging process at the cellular, genetic, and epigenetic levels, then the potential was that we could intervene effectively in age-related diseases. In fact, as you'll see, that's probably true. The example I'm going to focus on today is aging in the central nervous system. And these are two common sayings that are run into among researchers and investors. Everything works in mice, but nothing works in humans, which of course is not true because most things don't work in mice either. But it's very difficult to translate them into human trials, which is why that second statement is there. And most investors realize that Alzheimer's is a graveyard of companies, and that's been a real break on a number of startup biotechs as well as big pharma. So that statement, everything works in mice but nothing works in humans, was sort of the keynote of a conference we organized in Washington about 3 years ago. The Alzheimer's Association and a number of us got together to organize this. It was an animal models conference. And this is the question that was running through our mind. And it's one that I had to address in summarizing the conference at the end of the day, because as I say, things tend to work relatively well in rodents and various animals, including a number of primates, almost all of whom have bitten me in my research career one time or another. But it's hard to translate these into human clinical results. So the problem I suggested was that we often are digging in the wrong place. We focus appropriately on biomarkers as targets, as things to measure, but we tend to assume that it all stops there. And we don't go back before that and ask ourselves what causes those beta amyloid, for example, to accumulate, or tau tangles, or neurofilament light chains, or why the genes have an effect downstream, and why we see inflammatory changes, microglial activation, and so forth. And the problem, as I say, is that when you're digging in the wrong place, it doesn't matter how big your NIH budget is, or the case of Biogen Eisai, for example, the $1 billion is spent on lecanemab. The problem is that digging deeper doesn't help, no matter how much effort and money you put into it, if you're digging in the wrong place. And in fact, that's what we see when we look at the data. This is taken from clinicaltrials.gov. This was taken on 9/20 of this year. And as you see, there have been this many trials registered on that website. And by global consensus, anakinumab notwithstanding, these have all been clinical failures. So the question is, why are they failures and can we do better? Not just can we find better measurements for our biomarkers, but can we in fact find a way to make those biomarkers come out effectively? And to date, we have generally failed. Here's an example. These are the monoclonal antibody studies summarized, and not entirely all of them. There is one, the anakinumab, that was released by the FDA in June of this year. There have been a number that have been failures, although some of them may be retested. And there are a number that are still in the pipeline, some of which have achieved expedited status. But even when you look at anakinumab, what you see is this sort of result. And it's the same result you see in solanezumab. What you're seeing is that no matter what dosage level you look at, and number 3 dosage level takes a while to curve, you get these temporal step-offs that suggest you're postponing the pathology slide for a number of months, in this case, about 6 to 8 months. But the same is true of the solanezumab data. And then you see this recurrence of the downward vector, and it tends to parallel the placebo vector seen here in yellow, which is not what we would like to see. What we want is not an additional 6 months in the nursing home, for example. What we'd like to see is stabilization of the disease course, or in fact, improvement, if that were possible too, which it might be. But so far, that's where we failed. So what I'm suggesting, that when it comes to age-related dementias and another number of other diseases, we know a great deal about biomarkers, for example, but we don't understand very much about the process that results in those biomarkers. And that is really key. So the result of that conference was that I was invited to put together this paper, which came out last year, the Unified Model of Dementias and Age-Related Neurodegeneration. And I've never had a paper that had 8 reviewers who were all positive and that generated hundreds, literally hundreds and hundreds of global requests for reprints. But the point really is not that the model is correct in insisting, but that clearly other people see the need for that understanding too, that deeper understanding of the process that results in the biomarkers that we measure. So let me separate this into a unified model and a systems model and talk for a moment about what I mean by a unified model. What I mean by that is that we need to be able to understand the process itself, the underlying process. We have a lot of upstream biomarkers, example, genetic biomarkers that increase the likelihood of various downstream findings, clinically and otherwise. And these include things like head trauma, closed head injury, a number of cardiovascular factors, for example, hypertension and hyperglycemia, microbial infections, exposure to radiation. There are a lot of things that we know that tend to increase your risk downstream. For example, exposure to paraquat increases your risk of Parkinson's, increased risk from dioxin for a number of demential diseases. But we measure the downstream biomarkers, but without any real understanding of how we go from those upstream risk factors to the downstream biomarkers. So the question is, what is that underlying process? And my suggestion is that it has to do with cell aging. But before I get into that, let's look a little more broadly at the systems or the unified issue with regard to, for example, dementias. These are a number of very well-known typical dementias, by no means all, as you'll see in the next slide. But what you find is that while these syndromes are all too real, there tend to be an overlap. For example, Alzheimer's is classically a cognitive decline, that is, in terms of executive function, memory, a number of other cognitive processes. But many of these patients also have motor function problems. The same is true of Parkinson's. Most Parkinson's, for example, will have an uphill rolling tremor or inability to start a motion, as I've seen in my practice and many of you have seen. But many of these patients also have cognitive issues as well. And likewise, when we look at autopsy, many of these patients have vascular dementias underlying. So we know that these syndromes are, as I say, quite real. I don't mean to denigrate the clinical syndromes or the clinical diagnosis, but we do tend to recognize that when it comes to reality, there are a lot of atypical and mixed dementias. So while there's this, again, alphabetic litany of various things, for example, posterior cerebral atrophy and Lewy body disease and so forth, there's overlap. There are patients who are atypical, there are mixed dementias. And over the past decade or so, I think a lot of people have come to suspect that there is a unified fundamental process that is shared among many of these patients. And although they start in a very different way, genetically, epigenetically, and in terms of behavioral history, and they end up in a very different place in terms of the actual clinical syndrome and diagnosis involved, that between there is a unified process that depends on where you start, and that tells you about where you're going to end, but the process itself is very similar. And the same thing is probably true with regard to cardiovascular disease. If I look at my experience in clinical medicine, many of these patients have, for example, myocardial infarctions or strokes. Many of them also have congestive heart failure, and there is sometimes overlap. So many patients also, as we get older, have capillary pruning. And the same is true when I look a little more broadly at a number of cardiovascular syndromes. We see patients who share many of these features or have atypical features. Their angina is atypical, their congestive heart failure is atypical, their peripheral vascular disease, or their varicose veins. They may be shared, or they may be typical, they may be in one limb or another, and yet the suspicion is that we're looking at something that is shared among them. There's perhaps a fundamental process, and again, depending on where you begin genetically, epigenetically, behaviorally, where you end up may be different, but the underlying process may be shared. And in fact, the shared item is almost certainly cell senescence. This is true whether we're looking at central nervous system cells, for example, neurons and glial cells, endothelial cells, that is vascular endothelial cells in the vascular beds, chondrocytes in joints, osteocytes in bone, renal podocytes and chronic renal failure in the elderly, leukocytes and immune senescence or skin cells and skin aging. There's a shared process, and that process appears to be cell aging. Now, when I talk about a systems model, again, I'm looking at something a little perhaps more subtle than just the unified model. So let me give you an engineering example. This is, you're looking at the cockpit of an Airbus 380 and a Rolls-Royce jet engine that powers that, and the Trent 900 turbofan lower right powers the jet engine. And there's a single fan blade. Well, when that fan blade fails, an experienced engineer doesn't simply ask, what's wrong with the fan blade? They ask what's wrong with the fan blade in the context of the Trent 900 turbofan, in the context of the Pro 15 Rolls-Royce jet engine, in the context of the Airbus 380 at 35,000 feet, going hundreds of miles an hour at a high temperature and high RPM. That is, the failure of any component has to do with the gestalt, that is the overall process of the way this is used in action dynamically, rather than simply looking at it as a biomarker itself. And the same is really true in medicine. These are typical biomarkers, that is, signs and symptoms of a COVID infection, but by themselves, they are not a COVID infection. And it behooves us clinically and as researchers to be able to measure these sorts of biomarkers in a COVID infection, but by itself, that doesn't tell you how to cure one. The same thing is true when we look at age-related diseases. So for example, these are age-related biomarkers at the macroscopic level, but they're not aging. They're very common, and it's very common for us to measure them clinically and in research studies, but by themselves, that's not the process. Nor when you look at a lower level, microscopic level, do you find it any better. So while we know that telomere shortening, acetylation, and methylation changes epigenetically, there are all sorts of changes at the microscopic physiologic levels in aging. By itself, that doesn't tell you what the process is. You've identified biomarkers which need to be measured, but it doesn't help you understand how those biomarkers function. Same is true when we look at biomarkers for the dementias. These are common biomarkers, some of which we've known for more than a century. For example, beta amyloid plaque, first reported about 111 years ago. Tau tangles, not much less than that. But some are newer, like lymphatic changes and failure of the blood-brain barrier system, things that we've become aware of. And all of these biomarkers and others are not dementia. They are biomarkers of dementia. It's critical for us to know these, to measure them, to understand them, to get them reliably, get valid biomarkers. But by itself, it doesn't identify the process or an effective point of intervention. And the same is true when we look at the genetic level, because the genes don't tell us how the process works. We know, for example, that patients with 2A4 alleles have a much higher risk of Alzheimer's, but it doesn't tell us why. And there are more than 200 other genes that I can identify that have been looked at as increasing generally your risk for a number of age-related dementias, but they don't tell you why that happens. So in some sense, these are genetic biomarkers, but they are not the same as understanding the disease. Now, this is a quote that I found useful from a friend of mine. This is Dr. Leonard Hayflick. It was 60 years ago this year, he first identified cell aging. And in a discussion he and I were having, because we still talk, he said this, and the point he's making here is one that I want you to think about, which is that we all realize that when it comes to age-related diseases, for example, the increased risk of cancer, the increased risk of dementia, the increased risk of cardiovascular disease, we all recognize that aging is actually the best prognostic or the best predictive risk factor in these diseases. But almost universally, we then ignore aging and we focus on the histology, the biomarkers, the downstream physiology, without asking what aging is and why it causes what it does. We tend to assume we already know that. And I'd like to point out that if we want to alter that as a suggested we might be able to do 25 years ago at the NIH. What we need to do is understand the aging process. We cannot simply assume we understand it. We need to go a little deeper and understand the complexity and the sophistication of it. So to do that, let me start by suggesting that we don't know. These are, in a sense, some friends of mine. Human beings typically live about 3/4 of a century at an average. Gorillas live just on the average a little less than a half a century. That is Coco, the gorilla who spoke sign language. I know her well because I had to babysit her for a year when I was at Stanford years ago. Typical domestic animals last something short of or around 2 decades, depending on the breed and species. Typical rodents last 1 to 3 years, again, depending on breed and species. Now, you can't very well say aging just happens without identifying why it happens at different rates in different species. And most of us would then wave our hands and say it's genetic, which is a beginning, because we recognize, for example, that typical mouse that you see there shares about 75% of protein expression genes, not to mention the regulatory components, with you. And so we tend to ascribe the differences in aging rates to that other 25% and the regulatory components, which is not an explanation. What we've done is simply told ourselves where to look without explaining why it works. The same is true even when we can nail it down to a single gene. So for example, if we look within a single species at human beings, we might look at Hutchinson-Gilford progeroids. 25 years ago, I gathered these children together, these 30 children, on the North Portico of the White House, where I'd just taken them for tours. I gathered them every year in various places. And these children die overwhelmingly of age-related diseases with a mean lifespan of 12.7 years. And they typically die of strokes and heart attacks, as every child in this picture did within the next few years. But why? Well, we know the gene, or we think we do, it's the lamin A gene. But the question remains, why does the lamin A gene, or an abnormality of the lamin A gene, result in a rate of aging, which is about 5 or 6 times your aging rate and my aging rate? So again, identifying the gene does not tell you how it works, how it functions, why aging works at a different rate in these children than it does in most of us. And in fact, there are cases where aging does not occur. So every cell in your body right now derived from a fertilized ovum. That ovum derived from your mother, where it was a couple of decades old. She got it from her mother, who was already a couple of decades old. And we can trace that line of cells back in an unbroken biological line, just about 4.5 billion years. And that line of cells had no evidence of aging when you inherited it as a fertilized ovum prior to your birth, at your conception. And yet most of your somatic cells demonstrate age-related changes now. So why did aging apparently not occur for 4.5 billion years, roughly speaking, and yet it does in you now? Many people would ascribe this to mitochondrial failure, which doesn't get you very far because every mitochondria in your body now derives from your mother, who got it from her mother, who got it from her mother. And that line goes back, depending on who's making the estimate, something short of 2 billion years. And when you inherited those roughly 1.5 billion-year-old mitochondria, they had no evidence of age-related changes at conception. And yet, were I to measure mitochondrial function in your cells right now, I would find subtle but pervasive changes in almost all of your somatic mitochondria. So why is it that aging occurs in some cases, not in others? Aging occurs in some mitochondria, but not in others. And the answer is that we tend to misconstrue how aging works and cell aging works. We tend to think of it as just entropy, where it actually is a balance between entropy and maintenance. And what you find is that aging is actually a subtle failure of maintenance in the face of entropy. So example again, if we look at the germ cell line, what you find is that maintenance is essentially flawless over that retrospective time period of 4.5 billion years. But you see subtle failures in maintenance in your somatic cells, for example, the cells of this 80-year-old man's hand in the wheelchair on the left. Whether I look at his fibroblasts, his keratinocytes, his macrophages, his vascular endothelial cells, his microglial cells, wherever I look, I see subtle changes and failure of maintenance in the face of entropy, with the result being cell aging. In fact, it's sort of like red queen theory in biology. This is the quote taken from Through the Looking Glass by Lewis Carroll, where the red queen said, "We must run as fast as we can just to stay in one place." And that's precisely what most molecular pools in your body do. They're continually running in place. So whatever molecular pool I'm looking at, whether it is, for example, collagen, elastin, beta amyloid, cytochrome C oxidase, myoglobin, wherever I'm looking, I find that these are not static pools. They're continually being recycled and turned over. They are effectively running as fast as they can to stay in one place. And in a young cell, that rate of turnover is rapid enough to wash out any molecular damage. But as cell senescence progresses, what you find is the rate of turnover slows down, and this has been measured. And you find, therefore, there's a gradual accrual of dysfunctional molecules, with the result being damage and cellular dysfunction in senescent cells as they become more senescent. And in fact, you can look at this mathematically. This is taken from my Oxford University Press textbook on the topic. And really all this says is that young cells with a high rate of turnover per unit time have a low overall percentage of damage at equilibrium, whereas older cells with a slower rate of turnover per unit time will have a higher overall percent of damage, again, at equilibrium. So you're more likely to find damaged molecules in old cells that are ineffective and not being able to do their job than you would in young cells. So if I look at an example of this, central nervous system aging, in this case, for example, Alzheimer's patients, I could look at any number of different biomarkers, but amyloid is one I'll take right off the bat as an example of this. And when you look at young cells in the brain, what you find is that microglia, for example, are rapidly producing beta amyloid. They are secreting it, they then rebind it, they then re-internalize it, they then degrade it, and then produce it again. So you're continually turning over beta amyloid in young cells, but that rate of turnover slows as we get older. So the typical 40 or 50-year-old, for example, has a slower rate of beta amyloid turnover. And the result is you begin to get a slight accrual, increased percentage of denatured, in fact, beta amyloid molecules, and you get beta amyloid microaggregates. Now, one question might be, what about the genetic risk factors in this? And what you find is that if you have, for example, two ApoE2 alleles, which have low risk, you tend to make beta amyloid molecules that are essentially not very sticky. So at a same slower rate of turnover, you're still not getting as much in the way of damage, so you get fewer beta amyloid microaggregates and better cell resilience. On the other hand, if you have two ApoE4 alleles, you tend to make stickier biomolecules, in this case, beta amyloid, and so you begin to get more in the way of beta amyloid microaggregates for an equivalent age compared to someone with two ApoE2 alleles, and hence a higher risk factor, earlier onset, more rapid progression. So that's how the genes play a role. But as we get older, regardless, that rate of turnover goes down. So not only microaggregates go up, but frank beta amyloid plaques can be seen on postmortem histology. This same results in cell dysfunction, necrosis, and what we see clinically as dementia, in this case, Alzheimer's, Lewy body, and so forth. And the same is true, by the way, when we look at tau proteins, mitochondrial proteins, inflammatory changes, and so on. To give you an example of this, let me look at mitochondrial dysfunction. What you find is that about 99% of the aerobic enzymes in your mitochondria are imported from the nucleus. And what you find is that cell aging as it progresses slows that rate of turnover. So the molecules become more damaged by percent in the mitochondria, hence less functional, hence less able to produce ATP and more prone to producing free radicals in this case. So the ATP to ROS ratio goes up. The lipid molecules that keep those reactive oxygen species from escaping the mitochondria and the cytoplasm are also being turned over more slowly. So you get more and more oxidized and damaged lipid molecules in the membrane, so increased membrane porosity, so increased leaking of free radicals. You have scavenger molecules responsible for catching those. For example, you could look at catalase or superoxide dismutase, any number of the superoxide dismutases, and these also are being turned over more slowly. So they're less apt to be actively scavenging. And finally, when you do get molecular damage, that is also being turned over more slowly. So for four separate reasons, you're finding mitochondria have this subtle defect in senescent cells, resulting in an exponential increase in damage. The same is true if you look at DNA. DNA is the only molecule in your body you don't recycle, you actually repair. But the four standard families of DNA repair enzymes, detection, excision, replacement, ligation, are independently all slower in their turnover rates, so they're a little less effective. So you have this multiplicative effect. Detection is impaired, excision's impaired, replacement's impaired, resulting in an exponential increase not only in DNA damage, but in cancer over a lifespan, not years. It's not a matter of how long you live, it's a matter of how far you turn down your turnover rate of these, or in effect, how much cell senescence you have. So overall, the model goes something like this. What we're looking at is a number of upstream inputs that have an effect at various levels on cell aging and cell function, and a number of downstream biomarkers that are the result of cell aging and consequently on clinical outcome. And overall, what's happening is that every time as we age, cells divide, the telomeres shorten, which has a measurable impact on the pattern of gene expression. And the critical impact on that is a slower molecular turnover, whatever we're looking at, which results in molecular dysfunction and consequently functional problems in the cells and often necrosis. And the answer to that, of course, is we end up with actual tissue dysfunction and age-related diseases, including the dementias. The problem is when we try to intervene clinically upstream, we find that these are not as effective as we'd like to. So, for example, it's all well and good to say avoid toxins and avoid exposure to radiation or head trauma, for example, or trauma to knees in the case of osteoarthritis. It's also appropriate for us to try to intervene and control hypertension or ensure that patients are euglycemic, but that doesn't prevent or stop cell aging, it simply slows it. The same is true, been true for downstream effects. If we try to intervene, for example, with beta amyloid plaque, in the examples shown above with monoclonal antibodies, we find these are not fully effective interventions. The question is, can we do better? The answer is the optimal point of intervention probably is not upstream or downstream, it's in that central feature. And the reason I say that is because it works. This is a paper from Andrea Bodnar et al., published in Science 23 years ago. And what she and her group showed at Jaron in California then was that if you actually use telomerase to reset telomere lengths, you effectively reset cell aging. And I mean that in terms of the pattern of gene expression, the morphology, the histology, the actual physiology of the cells. However you measure it, you find you can actually reverse aging in human cells, in this case fibroblasts, quite effectively in the lab. Well, can we do this in tissues? And there the answer is yes also. This is a paper publishing experimental cell research by Walter Funk and his group also at Jaron. And what they showed is that you can actually reset cell aging in human skin cells, for example, fibroblasts and keratinocytes. And when you do, you can regrow what appears to be young human skin from old human skin cells. So effectively, we know that we can reset cellular aging and tissue aging in the laboratory in human cells. But we can not only do it in the skin, we can do it, it turns out, in osteocytes, or for that matter, in vascular endothelial cells. So literally, we have known now for 20 years that you could take diseased coronary arteries, remove the, for example, endothelial and subendothelial cells, reset cell aging by resetting telomere length, and grow what appears to be in the laboratory young cardiovascular tissue, in this case, young vascular tissue. The same is true of organisms. It was first demonstrated now, actually some 10 years ago, by Rhonda Pinham and his group at Harvard, but what they did is alter the germ cell line, which doesn't help us clinically in medicine. But this was a very nice paper in Embomolecular Medicine by Maria Blasco's group. She's the director of CNIO Madrid, the De Jesus paper. And what they showed is that you could use mouse TERT to reset telomerase in living organisms, in this case, older mice. And not only do you see physiologic improvement and behavioral improvement, but lifespan increases. So the point here is that we're beginning to intervene at the organism level with reversing cell aging and having an actual measurable impact upon biomarkers. So the overall model is this. Cell aging itself is probably the central mechanism, and it's probably the optimal point of intervention if we're dealing with a lot of these age-related diseases. I say that because this model offers a good explanation for how the upstream risk factors have an impact on downstream biomarkers. It also explains the clinical heterogeneity in terms of age of onset, different clinical syndromes, and so on, based on the beginning conditions, genetics, epigenetics, and behavioral factors. The model also is useful because it turns out to be not only consistent with all the known clinical and research data, but it's been predictively valid. That is, ahead of time, it predicts the outcome of the Eli Lilly solanezumab trials and the Biogen ESA anakinumab trials. The model effectively predicts exactly what we see when we measure those biomarkers. It has a couple of benefits too. It is novel, it is technically feasible, and it's been proven to be workable in vitro, ex vivo, and in this case, in vivo in animal studies, making it worth trying. So our priorities for the human trials, which are now planned, above all, are credibility, because this is a novel model, and it's got an uphill battle, but also efficacy, safety, cost, and timing. We're going to take a target, initially it would be CNS target, but we'll move on then to cardiovascular disease and a number of other age-related disease targets. So let me ask two questions. The first is, can we effectively intervene in the aging process at the cellular and tissue levels? And the answer is yes, it has already been done. And the question really is, can we do this effectively in clinical patients, for example, in age-related clinical disease? And there the answer is the same one I've given my graduate students and my residents for years, which is a logical, coherent theory is a good starting point. It's like having good biomarkers. But really, the outcome depends on the data. and we'll see what the data shows. I'd like to thank you all for joining me today. I hope you enjoy the rest of the conference, and I look forward to talking to any of you who would like to talk to me about this. Thank you. Bye-bye.